Deepak,
Yes, sir.
how are you?
Fine, sir. How are you, sir?
Okay, when are we starting?
Yeah, we are ready, sir. Yeah, 1 second. We'll just Gayatri.
Sujit, is my background correct?
Beautiful.
Yes, sir. It's good.
You got a better light than I do.
Good afternoon, everyone. We are back with the afternoon session in the second day of the International Faculty Week 2021. Now we'll be starting the third session for the day on Neuromuscular Orthodontics by Dr. Fabio Savastano. I also take this platform to welcome the moderators for the session, Dr. Madhav Manoj and Dr. Deepak Jose. Dr. Madhav Manoj completed his BDS in 1997 and MDS in 2001 from the Government Dental College, Trivandrum. He then went on to pursue MOrth from the Royal College of Surgeons, Edinburgh, and in 2012, and completed his FDS in the year 2018. He is currently working as a professor in Department of Orthodontics and Dentofacial Orthopedics in PMS College of Dental Science and Research. Dr. Deepak Jose completed his BDS in the year 2008 from Narayana Dental College, Nellore. He then did his MDS from AJ Institute of Dental Sciences, Mangalore in 2013. He is currently working as the reader in the Department of Periodontics and Preventive Dentistry in PMS College of Dental Science and Research. I now invite the moderators to take over the session and to introduce the speaker.
Thank you, Gayatri, for your kind words. Respected Chairman, Dr. P.S. Taha, resource person of the day, Dr. Fabio Savastano, other dignitaries and attendees, a warm welcome to the International Faculty Week 2021 conducted by PMS College of Dental Science and Research, India. This unique presentation, Neuromuscular Orthodontics, is presented by none other than Dr. Fabio Savastano, who is a medical doctor and an orthodontist with extensive teaching experience in the field of neuromuscular orthodontics. He received his medical degree with summa cum laude from the University of Naples in 1987 and his specialty degree in orthodontics and pathology from the University of Padua in 1990. His main focus since then, in 1988, has been the application of neuromuscular principles to orthodontics. He developed a unique orthodontic diagnostic and treatment protocol and conceived the neuromuscular orthodontics as a distinct branch and for the orthodontic specialty. He has lectured extensively in Brazil, Spain, India, Bahrain, UAE, Canada, Czech Republic, Russia, Ukraine, UK, and Italy since 1989, with courses delivered to over 900 doctors. He has acquired an extensive experience for complex temporomandibular joint pathologies and maxillofacial surgery as a hospital consultant for more than 15 years. He was director and adjunct professor for the Masters on Neuromuscular Orthodontics at the University of Deval, Andorra from 2015 to 2017. He is a founder and president of International College of Neuromuscular Orthodontics and Pathology from 2006. He perseveres to improve diagnostic and treatment procedures together with Dr. Piero Silvestrini. And presently, he is adjunct professor and director of Masters on Neuromuscular Orthodontics at the University of John and continues to motivate skilled orthodontists in achieving a higher level of their profession with confidence. My colleague and co-moderator, Dr. Deepak Jose, will take you through the modalities for the question and answer session. Deepak?
Yes, thank you, Dr. Madhav. Yes, now we'll go on to the last session for today. It's on neuromuscular orthodontics by Dr. Fabio Savastano. So, any of you have any doubts, you can just type your doubts in the chat box so that we will discuss at the end of the session. So, Dr. Fabio, please, you can start. Thank you.
Okay, am I on? Okay, how's my audio? Is my audio okay?
It's clear, sir. It's clear.
Okay, I'd like to thank Professor Taha for this invitation. Thank you, the Peak and Madhav, for your introduction. I have quite an experience in your country. I've been several times all over India, and I've gone to some universities. Unfortunately, the last 2 or 3 years have been quite difficult, I think, for all of us, starting from the virus. I miss India very much, but most of all, I miss the South. okay? I think the climate there and, everybody's more relaxed. So you're kind of lucky to be there. Okay, if you can see my first page of the presentation here, you can see there are some symbols and logos here. This is the ICMO logo. I hope you all join ICMO. There is an ICMO India you can join. And here is Myotronics. This is a company. I have no financial interest with this company, but I use the bioelectrical instrumentation of this company. And this is the logo of my international association. Okay, let me see if it goes on. Okay, the first thing I'd like to start today is to read you this. Bernal-Jenkins wrote, whatever you can measure is a certainty. Whatever you cannot measure is an opinion. So the big difference between a neuromuscular orthodontist and a normal orthodontist, a classical orthodontist, is that we really measure physiology. We don't measure pictures or static things. We measure physiology. Physiology is especially linked to movement, okay? So we measure the movements of the mandible, how your tongue works and how your muscles are doing. Okay. Let's start the story. This is 1987. You can look at my head now. It looks like a watermelon. And actually, I had hair once. This is truth. And these are some doctors here that were with me in the specialty. And this doctor here is Dr. Balercia. His father was a friend of Bernal-Jenkins in the United States. And he imported in Italy neuromuscular philosophy. That is where I learned neuromuscular philosophy, and I was introduced to the technique, okay? So I was working on weekends instead of going around and having a party while I was a student in Padua. Okay, by 1994, I had finished my specialty and I was working hard with the mandibular kinesiograph. That is a system to record mandibular movements. And I was applying it to orthodontics, and I had my first invitation, international invitation, to talk about neuromuscular orthodontics in 1994. And this is me, I'm kind of tired here. And this is probably, this is Dr. Rohit Shadeva. He invented night-tie wires, okay, for Ormaco. And this is Paolino, I think. He was the director of university, the dental university there in Sao Paulo. It was a great time. You probably know all this because it was just read to you. I just want to add that whenever this is big, it doesn't really mean anything, okay? The message I want to leave you today and give you, the only message is that to try in all your career to search for the truth and don't take anything for granted, okay? Because that's exactly what I think I did for myself. When we were working on cephalometrics and we had discussions on 1 millimeter, I looked at myself and said, what am I doing? Hours wasting for 1 millimeter? What is this, on cephalometrics? Okay, so I started traveling in the years coming, and here are my picture of my two best friends in India. And I was lucky enough to meet a lot of smart people at all the congresses and courses I gave. And I could refine my technique and make it evolve like I was hoping to. I come from a little town, okay? A little town that is in northern Italy that is very close to Nice and Monte Carlo and Sanremo. You probably know these places. But Monaco, Monte Carlo is Nice is famous all around the world. I'm about 40 minutes by car. So if you ever want to come and see me, you have a lot to see on this beautiful French Riviera coast, okay? These are some pictures of my office, okay? It's not a big office. It's only about 200 square meters. We have CAD CAM. We have all the fancy thing and, CBCT, okay? And this used to be because we're changing it now, how I did orthodontics. I was working on 3 and then I have another fourth chair in another place, in another room. So I was working all together. We can't do this anymore because of COVID, and sanitary regulations. So now we're changing, we're making single rooms here, okay? I'm going to talk to you about some, I hope, new things for you guys. And first of all, I'll be talking to you about biotensegrity, okay? Because I want to change the concept you have about anatomy in the TMJ joint. Then I want to talk to you a little bit about kinesiography. I'm going to probably skip the bracket prescription SAVA system, and I'm going to go straight into neuromuscular orthodontics, where I'm going to show you a case, okay? Biotensegrity. You need a little time. You got to read a book, okay? This book here, written by Stephanie Levin, okay? Biotensegrity and Dynamic Anatomy. You have some artworks that are all over the world, okay? And the most important thing I want you to remember about biotensegrity is that all anatomical structures have a significance. For example, when I was studying anatomy and I was becoming a medical doctor, and studying anatomy, we would, open legs, for example, and we would skip the fascia. We would just cut them off. Unfortunately, to understand anatomy and physiology, fascia and the fascial system is very important. But most of all, if you can see the amazing things that a human body can do, you'll start questioning yourself. How can all this be only mechanical? Okay, there's got to be something that goes beyond the normal law of physics. Okay, so the biological structures, all of them, muscle, bone, fascia, ligaments, cell membranes, are made by tensioned and compressed parts. Okay, tension, you'll probably have the ligaments, the muscles, and tensioned will be your bones. Okay, and if you take a look at the artwork done for who knows biotensegrity, you'll see that this system you see here is just made of, there's no cement here, okay? There's no real puzzle making in this. This is all a sort of elastic, okay? Movable, the parts are all movable. It's just tension and compression, like bones and ligaments, okay? Buckbuster Fuller in the 1960s was an architect, and he started ideating what tensegrity was. Then biotensegrity was then added to and applied to human physiology. Okay, and these are some of the beautiful, beautiful puzzles you can buy on the internet and check by yourselves. Okay, I have this personally, and you can just build it. It's just elastics, okay, and little pieces of wood, okay, and you can build a structure. You don't need cement, okay? And check this. Check the vertebral spine, okay? It's been done on the foot and the skeleton, okay? And what I want you to remember is the fascial system. The fascial system is all over our body. It's everywhere. It's usually divided in deep fascia and superficial fascia. But the fascia, it divides and limits the muscle function, okay? If you open a leg, you'll see fascia all over. Imagine going from India to Europe and you have a suitcase. You can take all your shirts and pants and just bend them correctly and come over to Italy. When you open your suitcase, everything will be everywhere, okay? But if you take all your shirts and you put them in a bag, okay, and you take the air out, okay, and then you do the same for the other bags with all the other clothing you have, when you arrive, everything will be there as you packed it, okay? So it's also a system for limiting the use of energy in certain sectors, and most of all, it divides, okay, but works in a unison. Everything physiologically in the human body. It's anatomy that with the fascia becomes a more functional anatomy. Okay. So there are books on this you can go and read. It's very interesting. Okay. So where does this all bring us? This all brings us, in a different type of understanding anatomy. When we look at the joint, we probably look at the fact that we are loading, we think we load the joint the more you work hard with your muscles. It's exactly the opposite thing. The more, in 1680, Borelli started looking at the TMJ and the stomatognatic system, just like a system of load, fulcrum, pressure, and compression, okay? And of course, it seemed logical, okay? But some of you probably know that if you have no condyles, you can bite, okay? And compress food, okay? Even if you don't have condyles. So the concept of condylar compression and how the forces are distributed, okay, during clenching and eating and swallowing are different, okay? In fact, a doctor named Frankel, of course you've heard of him, I hope so at least, started describing the muscles forces and saying that they were working especially on the dentition and did not involve the joint. That's why we have a problem when we talk about articular loading, okay? Articular loading does not happen. TMJ dysfunction can happen, but that is when we have a malocclusion. A malocclusion can change the distribution of forces, and that can bring a pathology to the TMJ. But the TMJ will not have a pathology per se for loading if teeth are there to support, all the functions of the stomatognatic system. So the biotensegrity concept, okay, has been described all over the human body, okay, pelvis, elbow, knee, and of course also to the TMJ. And this structural design principle, okay, considers bones as the compressional elements suspended in a global network of tension muscles, ligaments, and fascia tissues. That means that our TMJ, with the muscles it has inside, is not only there as a structure made of muscles and bones, but all the fascia around it completes this network, okay? And works all together with the external fascia of the masseter and temporalis. So it's a one element thing, okay? Let me show you the short video where biotensegrity is demonstrated.
This is the very simplest model these together, those are right. Those come together, and they and if I expound
what is he saying? That the more you compress, the more you apply force to the TMJ, the stronger it gets, okay? That is the idea. It's a new idea that is just coming around, and it's been already demonstrated, okay? So we have to change our mind. The harder your bite, the stronger your TMJ is going to be. Now, you've seen people that are very strong go in the gym and take a big weight and just pull it up, okay? You probably start thinking that in the joints in their leg, the bones are going to come in contact and start destroying because of this weight. Actually, the more pressure they're holding, the stronger the joint gets and the farther away are the bones. It has been demonstrated already. The liquid that is in the joint is highly compressed and separates the bones in the joints, the higher the pressure is. Okay, so just to remind you that in the anatomy, this is the prediscal lamina, okay? The prediscal lamina, it has the masseter, the temporal, and the pterygoidea lateralis on it, okay? It has the masseter and the temporal muscle on the prediscal lamina, okay? And there's even more, but let's not complicate things today. There, you got another picture here. The prediscal lamina, and you got all the three muscles are here again. So start thinking of the TMJ function and start thinking that if muscles are relaxed, probably the TMJ will start working better and will coordinate in a better way. This is another demonstration of the muscles we're talking about. This is more of an anatomical microanatomy demonstration. Let me go to the main concepts of the philosophy. Okay, because that's what I want to introduce to you today. So now just look at this triangle, okay? Understanding neuromuscular philosophy is easy, but you have to follow me 10 minutes. It takes 10 minutes of concentration. If you don't have it, you won't understand what's coming afterwards, okay? You have on one part the TMJ, and we just talked about that. Then we had another part, we have the musculature, and now we have teeth. This is our stomatognatic system, okay? There's nothing really more to this. This is the three main things of the stomatognatic system. We have always been concentrated on teeth, okay? That is the wrong thing, okay? Now, the musculature is the only thing that moves, is the only thing that can change something, okay? And where does this order come from? It comes from the central nervous system, okay? The central nervous system commands everything in your body, everything except local reflexes. It commands everything, okay? But you have to understand that it commands it in two main ways. Either you're conscious of what you're doing or you're unconscious, okay? Okay. So the teeth send their information to the central nervous system, okay? Through the periodontal ligament. So does the TMJ, okay? And so does the musculature. They all send this information to the central nervous system, which elaborates, okay, like a big computer, and works on the musculature, okay, to adjust function according to physiological needs, okay? If you gotta swallow, you gotta swallow, because that's the most important thing for survival, okay? If you've got to talk, it's very important you talk, because you have to shout at your wife maybe sometimes, because she's going to shout at you every day, okay? So whatever the physiological task is, the more important it is, the more important signal the central nervous system will give in order that you preserve its function, okay? Now, imagine Mr. TMJ, Mr. Teeth, and Mr. Musculature sitting at a table, okay? and you don't want them to fight. Okay? You want them to become friends. Okay? And so Mr. Teeth goes, hey guys, how can we all work together in order for it to be harmony between us, in order that we can work together in concert, okay, without fighting each other, without giving pain to each other. Can we do that? Okay. Now I want you just 1 second to listen to this. Okay. Now, can we change tooth position? Yeah, sure. We can change tooth position. And if we move teeth or change them or extract them, okay, or put buildups or whatever, we are working on this part. We can really work on that. We've been doing this for all our lives, okay? Can we work on the TMJ? Yes, of course. The more we work on teeth, the more consequence we have on the TMJ, because teeth are in the mandible, and the mandible is the condyle. And if we move teeth, we move the condyle. Always, always. There's no chance we're not going to move the condyle. Okay? What can't we do? There's one thing we can't do. We will never change the insertion, okay, and the intrinsic function of the muscle. The muscle will always be there. You can move teeth, but you can't move the insertion of the muscle. Yeah, probably you can do it in surgery, but we're not there to talk about surgery today, okay? So you are there that, you know, you have these three sitting at the table, and in order to accommodate all three, you have to work for the muscles. The only ones you can't change. So if the muscles dictate the ideal function for them, then we can accommodate teeth accordingly. Okay, that is the idea of the neuromuscular theory. Now, I'll go quickly through this. I don't want to really hassle you. You're probably tired of a full day. Rules for occlusal force for each tooth contact. All forces must arrive at the same instant to avoid premature contacts. That's easy. Come on, everybody knows that. All forces must be of the same magnitude. Yeah, I agree on that. Each occlusal force must be actually oriented to its individual tooth order to avoid mandibular displacement. Of course, these are logical considerations. Please read Dr. Lehrman, A Revised View of Dynamics, Physiology, and Treatment of Occlusion, a New Paradigm, Cranio, okay? Now, what is accommodation, okay? Accommodation is a muscle reaction triggered automatically when they're not working under perfect conditions. Nobody's perfect, so everybody has a certain level of a muscular accommodation. Everybody has a certain level of malocclusion. So more or less, we all have accommodation. Okay, and this accommodation requires the central nervous system to not think every time we close in centric occlusion. We know exactly where centric occlusion is. We can go bang, bang, bang on the centric occlusion in a very precise manner. You can take a hair, put it between your incisors, and bang, bang, bang on that hair, okay? That is called muscle memory. That's the engram. That is a way that our central nervous system is using to use up less energy, not think everywhere over, where are you and where are you going, Mr. Mandible, okay? So if we go back to that triangle I showed you, okay, you understand that TMJ and teeth become the passive elements of the stomatognatic system, while the musculature is the only active element. What I'm trying to tell you this is that when you look at dental cast, the teeth have all the information. The muscles have tried to adapt to that malocclusion and have given, okay, during swallow and other moments of the central nervous system working on the musculature, they've tried to force or they're trying to beat the malocclusion, and they're leaving those signs on teeth, okay? So this engram, okay, this muscle memory only lasts for, about a minute or two. Then it goes away. Then the central nervous system has to start working all over again. That is why what we do in neuromuscular orthodontics and neuromuscular philosophy technique is that we put something between the teeth so that the periodontal ligaments do not send the information to the central nervous system, and we can distract the mandible and check where the muscles want to bring the mandible, okay? If you have time, I have some publications that talk about this and explain and talk about occlusion. Okay, let me give you an idea of what happens. This is a classical class 2, division 2, you would call. If I ask my patient to relax, this will be what happens. This is what you're going to look at. He's going to relax, mandible is going to fall down. This space, this interocclusal space is called freeway space, okay? And if I apply TENS, okay, for 45 minutes, this is what I get, okay? Okay, look at this line here. Okay, this is a class 2. This is when the patient relaxes, the mandible falls a little back and down, okay? This is after I relax muscles. It seems, okay, it just went straight down. Actually, the path of closure, okay, that is always about 45, 60 degrees, will want this mandible to come in class 1 occlusion. It cannot, because the central incisors are pulled back, okay? So what we do is we find out, okay, that's the path of closure, okay? We find out the hidden characteristics of the individual, okay? This is the exact same thing. This is kinesiography. This is the centric occlusion when bite is together, okay? This is the upper incisor, okay? This is frontal, this is sagittal, okay? This is that we've relaxed muscles here, okay? We've relaxed muscles here, and this is the path of closure, okay? On this horizontal plane of occlusion, the patient's horizontal, the mandible would want to be in a more forward position. Okay. So these techniques can be done on everybody. I do it also on children. Look at this little girl. I'm going to test her muscles. She has very complicated dysfunctional occlusion. And I'm going to what I'm doing here is actually I'm doing electromyography, but I'm also stimulating with TENS her muscles, okay? It's like a little game we play together, okay? This is another child in which I've taken a new bite, okay? Just with the TENS application, okay? This is a girl, okay? We have great time together. You got to play with children. This is the more complicated part. We are recording mandibular movements in this child, okay? And when we recorded that new position we want, a new centric, we can build our orthotic, okay, which repositions the mandible according to muscular needs. Funny enough, it repositions exactly where the TMJ functions perfectly. What we do after recording, if the patient has clicks before, we put the recording in their mouth and they don't have any clicks anymore, okay? We use the aqualizer as the interocclusal media to stop that information from going to the central nervous system, okay? This is this is the prescription and the solid prescription for neuromuscular orthodontics. I'm skipping this. And what is neuromuscular orthodontics? To give you a small summary. We apply neuromuscular dentistry principles to orthodontics. We focus on function. study muscle function with its neurological and anatomical aspects. It identifies as malocclusion as the main, but not the only factor of TMD, determines mandibular posture as the most important diagnostic factor. Where does the mandible want to be? Where do the muscles want to bring the mandible? And we use the bioelectrical instrumentation for the diagnostic procedures. So when we go back to this scheme, we can understand the objectives of orthodontic treatment from a neuromuscular point of view. First of all, the occlusion is the result of a balanced function of the muscles. Okay, think for a second. You're an orthodontist, okay? Doctors, a lot of you orthodontists, what is relapse? What is relapse? I'll tell you what relapse is. Relapse is a big muscle problem because you had creeped in a class 1 occlusion, and after 2 months, you've taken braces off, and it's a class 2 again. That's a relapse. It's not a single tooth rotation or a disalignment. It's a change of class occlusion, okay? That is a big relapse, okay? So it's muscles that decide where the mandible is going to be, not the orthodontist. You can try to create your class 1, but if the muscles won't accept it, I don't know how long it'll take, but sooner or later, that class 1, if it's not supposed to be there, it's going to pay a price. Either it's going to be becoming a class 2 or a class 3 again, or it's going to be a TMD problem. No other chance. Habitual rest position of the mandible, the habitual rest position, what your everyday rest position is the result of relaxed posture of muscle. I'm sorry, it's not supposed to be. It's the physiological rest position. I mean, there's a big difference between physiological and habitual. Habitual, you have accommodation. It's like you are every day. Physiological is when we relax the muscles. So the rest position, which is important for us, is recording that position when we relax muscles. So we do all our malocclusions, the muscles adapt. This is, stressful for the whole system. We relax the muscles with TENS. We find a new rest position. We record a new centric. And from there, we can apply therapy, which can be orthodontics or prosthetics, okay? So you that are dentists, I'm asking you, when you have a severely damaged condyle, how are you going to reposition that? I mean, patient has pain, arthrosis. How do you know where that is supposed to be? You don't know where to place that. I do, because I'll let the muscles decide which is the most important position of the condyle, okay? And there's a lot to say on this. I'm going to go a little bit quicker, but I want to just remind you that condylar retrusion, distal position of the condyle, is the most frequent position in pathological TMJ. That means in TMD problems for the general population. Now, thinking 3D actually is not supposed to complicate your life. We know that the whole function is 3D, okay? And so we know that the mandible can change position in relationship to the cranium. So there is a big relationship of occlusion, but more than specifically occlusion, the mandibular position relative to the cranium, and as a result, head posture. So morphology, mandibular position is in relationship with head posture. These are just some of the publications. There are a lot more on this. Okay, there have been books written by Bousquet, Walters, Applied Kinesiology, the Fascial System. Fink, Dr. Fink has this publication on cranio in 2003. So we know there is a relationship. It's just that the farther you go away from your neck, the more complicated it is. In neuromuscular orthodontics, You know POSIL. You've studied that in your university. And what we're interested in is just this little piece right in here, okay? Centric occlusion, you can see that with teeth, centric relation is down and back, because if you search for centric relation, you're gonna have the cusps of your teeth have you slide back and down. And the posset, of course, is in relationship, okay, with head extension and flexion, okay? If you're there standing or sitting and listening to me, if you bend your head back or bend your head forward and you open and close your mouth, you'll feel the premature contacts of your front incisors, for example, or your premolars as you go back and forth when you open and close your mouth, okay? This is what we're all interested in, okay? And of course, you have on this side, you have a patient looking at your right, and this side, you have a patient looking at your left. And when you're doing cephalometrics, you may be working on this side, and you're doing kinesiography on that side. But at the end, okay, this is what we're interested in, no matter how we look at it. This is the frontal. We're looking at the frontal too. Now, since I want to start going to the end of this small, very brief introduction, it takes a 4-day course actually to really understand all the implication. I want to show you a very simple case, okay? And most of all, a class 2 case, okay? I don't want to really ruin your day of talking about class 2. Classical orthodontics teaches you exactly what class 2 is not, okay? Fortunately, some of you are getting closer to Sadao Sato, okay? And he has a clear vision of what class 2 is. Class 2 is not a sagittal problem, okay? Class 2 is a vertical problem. I know this sounds crazy for you, but I'll be happy one day to explain to you why. So look at this child here. She has big teeth. She's very smart, and she's very cooperative, okay? And this would be her x-ray, okay? And you would call this a class 2, and I agree with you because there's a nice class 2 occlusion, but the mandible is normal in size for sex and age, okay? So for me, it's called positional class 2. The mandible is there, but it's positioned in the wrong place. I would never, ever distalize the upper arch. I recognize that 95%, maybe 98% of class 2, what you call skeletal class 2, are skeletal class 1, in which the mandible is absolutely normal, the maxilla is absolutely normal, but they're positioned wrongfully, okay? So this is exactly what we have, a class 2 occlusion. We have a big overjet, we have big front teeth, beautiful, big, but beautiful, okay? She's a very healthy child. Look at this class 2. We're in March 2018, March, okay? Okay, March 2018. And we're looking at our overbite, okay? And all class 2 occlusions must be expanded, okay? This is a normal expansion for a class 2. I know you don't do this. It doesn't really matter, okay? When you have relapse, then you give me a call. I don't have relapse, okay? So you can see a box bite almost here. See how severe this expansion is? This is what's needed. All the rest, forget it. Expansion with a removable appliance, don't give me any of that. Don't give me any of the new fancy things you have out there. Rapid palatal expansion, this way, the classical way, or with the 2 temporary anchorage devices in the upper maxilla, fantastic. But you have to create more bone, because one of the problems of class 2 is bone deficiency transversely for the upper maxilla, okay? So we're there and we're in April, from March to April. Okay, we just did this. Okay, March to April, we just did expansion. Okay, and I start putting my fixed appliance on the lower arch. Okay, look at this. This is a box bite. Are you afraid of this? I'm not. I know what I'm doing. Look at the box bite. That's a normal expansion. Okay, now we're in September. You see, started in March, did the expansion, had to wait some, and then in September, I start putting my fixed appliance, okay? What do? I record the mandibular position. I am in September, and I see, okay, let's see where this mandible wants to go, okay? And here's the video for you guys. Okay, this is our case, class 2, deep bite, excess freeway space. Look at that overjet, it's real big, okay? Still some silicone in here. What I did is I recorded a new position after tensing. And this is the position we got. Let's check it out together. And that's the new position. And if you look at it this side, it's almost a class 1 occlusion. Look at the overjet now. Really reduced it. And let me take that out so you can see it again. Open, close. That's the big difference. Open, close. So we just made a bionator here, and this is how we're going to insert the bionator. And this is done on a neuromuscular position. Here. There it is. What we're going to do, we're just going to reduce this right here in front. We're going to take this, all this piece of the bionator away. We're not interested in that. And she's going to decide if she wants to keep the lateral part here of the bionator, or if you want to take that away too. And then we're going to start extruding our teeth. And we're going to eat some extra space for the incisors. Copy that too? Thank you. Okay, so if you take a close look, look, it's a nice box bite. Isn't that beautiful? That's an expansion. That's what I call expansion. Okay? Now, here's the modified bionator. You can see we carved what we want to obtain with this bionator. And open up. There you go, baby. Close. There we go. This is what we're looking at. Take a look here. We're going to start extruding here. This is going to work more like a stop here, the lower 5, and extruding up here. Plastics, we're just going to start with something very light so she can get used to it. There's 1/4, 6.5 ounce going on both sides. And that's just it. This is after 2 months. And these are the elastics she's wearing, your box elastics. And now we're going to check how her occlusion is. And this is the bionator. And this is, you can see there, this is what we've been doing. And now we can go and check what is the difference with the previous occlusion. So now you can see there's a big result here. First of all, looking straight in front of her, you start to see the brackets. And let's take a look at the overjet. It's almost done. And she is about to slide in a class 1 relationship. She has a lot to extrude still in the posterior, but the premolar is already working fine for us. That's what we're looking for. Molars will come later on. And let's take a look at the profile. Much better. So how do you like it? 2 months to treat, 2 months to treat mandibular advance, to treat with mandibular advancement, a class 2. And you saw the elastics because the secret is the correction of the posterior vertical dimension, okay? So these are some pictures you can see how I started carving because I started working on the premolar area, okay? You can see how flat the molars are, okay? I'm going to correct the torque here, okay? And I'm going to be doing extrusion here, but this comes later. First, I want my occlusion to be balanced on the premolar area. This is October 2018, okay? This is exactly what you saw in the movie, okay? That's the extrusion part. And in November, you can check the occlusion, and the occlusion is already going class 1. This is already a class 1 for me. Case is already finished for me. Please look at this. Look at the space here, okay? I still have to work on this torque and this upper molar, okay? I know it's going to take work here. I know it's going to take time, but no rush. I want my occlusion is finished here, okay? And in November, I start working also on my upper front incisors, okay? And there you go. I'm in February 2019. I'm finishing my case. I can see finally, my lower incisors. Look, there's no intrusion on lower incisors and there's no intrusion on the upper incisors. If you intrude in open bites because you close the bite by intruding, in deep bites, you have to extrude. So let me go forward. This is the change up to this moment now, not final, okay? And first of all, these are pictures taken in natural head posture. When you use up freeway spacing, you increase the vertical, there is head extension. And this is what happens. So besides the profile per se, you have a big change in head inclination. You can check on this publication if you are interested. Okay. And if I correct the posture, I can see the mandibular advancement with an overlapping here. And I'm not done yet because I know it's going to get better. Okay. And this is the frontal. We're in March. Okay. And here I'm finishing. As you see, I start to correct the posture and I'm coming into occlusion. Okay. I still have some tipping here. You know, I'm still at the beginning. The profile looks much better. And these are the steps, okay? 1, 2, 3. This is the change, okay? I showed you before. And I finish in November 2020, okay? And nice big teeth, beautiful class 1 occlusion, but I check it in April 2001, and I am still very happy. And this is the final profile, April 2021. This is how we started. I want you to look at this. Look at this angle here. And look at this angle here. Okay? And this is before and after, before and after. And this is before with the overlapping halfways and after. This is her profile now. And these are the x-rays. Yeah, I know there's, you know, she has more room for breathing and all that stuff. And, you know, I'm not here to talk about that. I'm not here to talk about that. And let me see if I can, wait just a second. Well, you can't see the nose here. I just cut that off. I wanted to show you this here. And thank you. And I'm ready to take all your questions. And, oh, Manjit is there. I can see Manjit. Is that him? Manjit.
Hi, Fabio. Hi. I am.
I showed a picture of you with Taha.
No. I feel like a student when I sit in front of you. And you know, when you're online, there's no fear that Fabio will ask question. You know?
Okay. I love the fact. I'm sorry. I'm at the Congress with all of you. I have no mask.
No. I'm in the clinic
Hanoi
actually.
and Jose don't have masks either. You can take yours off, right? Or maybe they're going to give us the information that the virus can mix through webinars.
No.
You never know.
No, I'm in the clinic actually. See, I'm in the office.
No, I'm actually in my office at home.
Great. Little pleasure seeing you, and the energy that you have. Oh my God, it's fantastic. Real pleasure talking to you. You know, I recorded a few expression of yours to get energy from you. Little pleasure. Thank you so much.
Bye-bye.
It was wonderful. Explicit lecture.
Thank you. Bye-bye.
Thank you, Dr. Fabio, for such a great lecture. I think it's very difficult to concise such a vast topic into a 1 hour lecture, and still
of
you've
course.
done a great job sending the message across. So the session is open for the discussion. If you have any doubts or question, you can please type it in the chat box. I'm sure Dr. Fabio will be more than happy to clarify your doubts.
It's okay. Okay. No problem.
So, Dr. Fabio, how do you feel? It's I think from your lecture, what I've understood, it's like a vicious cycle. Your muscular position and the TMJ, your body posture will also affect the occlusion, and occlusion, premature contacts, or even the restoration high points also can affect your function. That's what the neuromuscular disorders. That's what can you explain it?
Okay. There is some evidence, okay? I'm talking about scientific evidence, okay? Not I feel it looks this way, okay? There is some scientific evidence of a correlation between postural pathologies and occlusion, okay? We saw this already with people who had, that had to have back surgery and were living like this for 5 years, and they changed their occlusion. That's normal, okay? But in a healthy person that for some reason has a, for example, habit in the posture, will that affect occlusion? We have some evidence that that can be, okay? The fact that having evidence does not mean that automatically you have treatment in diagnostics, okay? That's a lot more complicated. So for now, the strongest evidence and what is clinically important is the craniocervical posture and all the way to the neck, okay? When we talk all the way to neck, we know a lot of things. When we want to say, oh, you have a premolar contact, so that is why your knee is hurting, that is still very funny for me. My thesis in specialty was the first thesis in Italy in talking on the relationship between posture and occlusion in 1987. And I just bought my third, okay, computerized postural analysis system, okay? And my son, he's an osteopath did his studies in London. He works with me on this. And I can tell you that it's still research after 30 years. So don't buy directly things like this. I think the most important thing anybody here should focus or coming out of a college is to how to create a functional working occlusion, how to have it pain-free, and most of all, how to deliver something that in 10 years will still be there without affecting the temporomandibular joint.
Thank you. So there's a question for you. So what is the criteria for the expansion required?
Excuse me, how fast do I expand?
No, the criteria, I think
Yes, how fast do I expand? Okay.
yes.
First day, I give 3 1/4 of a millimeter, and then 1/4 of a millimeter a day. That's 1 shot a day, okay? For about 15 days, and then I check how open they are. Now, you have to understand that it's very rare to have an overexpansion. It's very rare to have overexpansion. It's more frequent to not expand enough, okay? And you have to expand, but if he has big tonsils like this and adenoids, you're wasting your time. You need a surgeon too.
So how do you decide on the final result, that is for expansion? How far you're going to expand? How much of expansion that you're trying to achieve?
As much as I can,
Oh, okay, right.
okay? I don't want a box bite on my molars. I don't care about the rest of the teeth. I look at the molars and I want their lingual cusps almost to be out of occlusion, okay?
So once you've expanded, you remove the brackets on the lower mandibular arch, then remove the expander. That's all.
Not always. It depends on your case in which I had excessive torque in the lower arch, which makes the lower arch smaller. Okay? That's why I had a little bit of box bite. When I corrected the lower arch, that box bite went away by itself.
Oh, thank you. I think any more doubts? I think that's it, sir. Thank you so much.
Great. I can see Professor Taha there.
Thank you, sir. I invite our esteemed chairman, Dr. P.S. Taha, to present our token of gratitude to Dr. Fabio.
Professor Fabio, namaste. You are the father of neuromuscular orthodontics. I really appreciate.
Sukuma.
Okay. I'm really, a wonderful talk and nice. Thank you very much for presenting your lecture and joining us. And hopefully next year you will be one of our faculty in our institution for neuromuscular orthodontics. Okay, when the pandemic is over, you will join us as the professor of neuromuscular orthodontics. Okay.
Thank you very much.
Anyway, thank you very much for the nice lecture and being with us, and to make our students and faculty rich with knowledge in neuromuscular orthodontics. Thank you very much.
Thank you everybody. Bye-bye. Bye-bye.
I think Dr. Mani is online.
Yeah. Very much online.
You are not being seen in the, Yeah, please put your words of appreciation to Professor Fabio.
Dr. Fabio, hello.
Yeah, I'm here.
Yeah, Dr. Fabio. Dr. Taha told you that you're the father of neuromuscular. I think you become a grandfather of neuromuscular.
Oh, thank you. Just because
the grand way that you say everything, is such a wonderful thing, Huh?
Okay. I think the most important thing that Taha, you and I have at the moment, I can speak for us three because I know you two guys, okay, is that we've reached a certain age, okay, that we don't have to listen to everybody. We can do and say what we want, okay?
Yeah.
Short of freedom, it takes time. Don't rush, guys. It takes time. Because something very heavy to put this freedom on, okay? So it's fun lecturing, it's fun expressing my ideas, and I hope that I stimulated a little bit of curiosity for everybody there.
Too much of stimulation is not only stimulation, it's enticing, you know. Fantastic. Nice seeing you. Great. Thank you so much.
Thank you. Bye-bye.
Grateful
Bye-bye.
to you. Bye. Bye.
Thank you, sir. I take this opportunity to thank our moderators as well for the session, Dr. Madhav Manoj and Dr. Deepak Jose. I also thank our Director, International Relations, Dr. Manjeet Singh, for his participation. We have now reached the end of the second day of the International Faculty Week 2021. I take this platform to thank our chairman, Dr. P.S. Taha, and all the esteemed speakers, moderators, and attendees for their participation. The sessions will continue tomorrow, starting with Dr. Simon's talk on implant aesthetic at 9 a.m., followed by the session on digital dentistry by Dr. Henry at 11 a.m., requesting all participants to kindly assemble by 8:45 a.m. in the auditorium. That's all for today. Thank you and have a good day.